Good morning, everyone. For those of you who are from outside Calcutta, a very warm welcome to our city. And before I begin, I must really thank Mr. and Mrs. Samani and the entire Ratnabali team really for having all of us together and give us a chance to, play a part in their vision and hope and dream. And I'm pretty certain that it will happen, and it will happen in the manner in which they want. So, can I? Yeah, I think that's a very boring slide. Can we have the? Oh, I can do it. So sorry. Yeah, so basically, I'm a psychiatrist, and I work with children, adolescents, and adults with autism. And as you know, that autism is a complex disease, and often in a poorly resourced country like ours, when children and young people or adults come with a diagnosis and we start intervention, and intervention again in autism is a complex process, we realize at times that the intervention is not working, despite engagement of the family, despite really competent therapists. And then we start looking into why the intervention is not working. So then this question comes that, is there anything else which is going on in this child? Thank you. The other scenario, which is very, very common in our country, is that we get, suppose, a 25-year-old, 27-year-old who presents with frank mental illness. And then when we start treating the mental illness, suppose we think it is schizophrenia, it is bipolar, it is anxiety disorder, and once that picture clears, we are left with a residue which again we can't explain. And many of these persons who have gone through the mental health care system for years and years and have this thick bunch of file of doctors' notes, professionals' notes, and then we realize that the actual diagnosis which we had missed, or many of us had missed, is a developmental disorder on which superimposed was the mental illness. So over the years, what we have realized collectively as a team, that being aware of the mental illnesses which are actually exceedingly common in autism is something which we have to pay attention to. And therefore, I thought I will make this presentation. I must kind of large parts of my presentation is not mine. We work as a team and I take the credit. Monisha, who is not here, she is a clinical psychologist, has contributed a lot. Shanil, who is here, also had kind of made some very, very important observations. So what I'm going to talk about is this whole concept of comorbidity. What is comorbidity? How common, and I think this is a crucial question, how common is mental illness in autism? When you are thinking about autism, are you only thinking about the very, very complex presentation and symptomatology of autism, or are you also keeping in mind that this person could be having an additional mental illness? And how common is mental illness in this population? Why is it more common? Most importantly, how is it important? And again, a very, very vexed question of why do we know so little about it? And also why knowing more about it is important. See, comorbidity is co-occurrence of two or more disorders in the same person. So you would have autism, you can have anxiety. You can have autism, you can have schizophrenia along with that. And it is not as simple as that really. To make the picture more complicated, you can have autism along with anxiety, which can then, after 4 or 5 years, you can have autism in the same person which remains or kind of improves, and you can have a mood disorder. Or you can have mood disorder, panic attack, and substance misuse in a person with autism. So therefore, what we need to keep in mind that comorbidity, which is co-occurrence of two or more disorders in the same person, the key word is it can be the same person can have autism along with another mental illness, but also can have autism plus 2 or 3 mental illnesses. And the whole spectrum or the whole presentation can evolve with age. So it's not that you have anxiety disorder and that will remain anxiety disorder in this person for the rest of the life. So I think also recognizing that is important. Now, how common? There are landmark studies, in 1970s, possibly one of the world's best known child psychiatrists did landmark studies in a place called Isle of Wight, and subsequently the data has been validated. The bottom line is, okay, this is too complicated for me. The bottom line is that developmental children or anyone with developmental disorders have 5 times the more risk of developing a mental illness compared to a normally developing kid. So suppose you have 5% of the normally developing kid having a mental illness, anxiety, depression, emotional disorder, 25 out of 100 it would be the number in persons with autism. So it's a startlingly high figure. The sad part is that, developmental disorder contains a vast range of disorders. ADHD is one of the best known developmental disorder. All of us who are seeing children with ADHD are very conscious of the comorbidity. We know that a child with ADHD can have SLD. We know a child with ADHD will be prone to develop emotional disorders. But somehow, when we talk about autism, the whole notion of comorbidity is sometimes hidden. We don't think of comorbidity with autism, except we think of ADHD and autism and maybe seizure disorders with autism. But therefore, we are neglecting a vast array of mental illnesses which are actually very, very common in this population. This whole question about why we miss it and what is the impact of missing the comorbidity. I think there are multiple reasons why we miss it, because we all operate in silos, isn't it? So I am a psychiatrist. I have a very poor knowledge of developmental disorders. So therefore, I don't see the autism part when I am evaluating a person with mental illness. Now, for a developmental pediatrician, they are fabulous in evaluating the developmental aspects. They pick up autism, but they miss out on the mental illness part. Therapists, they come from their specific background and they would evaluate, they would think in terms of, their specialization. So an occupational therapist, behavioral psychologist, special educator, psychiatrist, developmental pediatrician, we all operate in silos. And therefore, we miss out the fact that a person with autism will and do have mental illnesses, because we are, it's like this famous cartoon of watching an elephant from different sides of the room really, and we miss out on the whole picture. The impact of missing the comorbidity, which is obvious, the impact is the intervention is not working. We are left with inexplicable meltdowns. But even more than that, one of the most significant problem of missing the impact is one of the most significant impact of missing the mental illness part of autism is this finding. This finding tells us that the mental health of parents of children with developmental disorders is more dependent on the child's mental health than on the child's developmental level. And if you think more about it, it makes sense, because often parents and carers, they come to terms with the developmental disorder, they work with it, but if an superimposed mental illness happens, that brings on unpredictability, that brings on inexplicable behavioral changes. So many parents and carers, they find it very worrying, they find it very perplexing, and also they find it very demoralizing that despite their best efforts, the child is not progressing, or the person or an adult with autism is showing strange behavior problems which they can't make sense of, and it definitely has an impact on the mental health of the parents or the carers. Now, what is the impact of mental health of parents on children or young people with autism? So if the mother is depressed, if the primary carer is depressed, then obviously the interventions won't work. So the point I'm trying to make is that research has shown us that the mental illness in persons with autism has a significant impact on the mental health of the parents. And the mental health of the parents, again, has an impact on how we are going to work with the family and how this child or the adult or the young person is going to make progress in the therapy. So therefore, it is all tied in together, so which makes our case of detecting mental illness in persons with autism even more stronger. Right, so what kind of comorbidities are there? These are the, the obvious range comorbidities. I'm not going to talk about ADHD because all of us know about ADHD. There are a couple of, items in the blue below. Gender identity. In case I run out of time, I tend to talk a lot more than I should. I actually wanted to, before I go into the other things, we do see a large number of young people, not large compared to the Western context. Western services, at least USA, UK, Australia, they are now overwhelmed with kids wanting gender reassignment interventions. We do see some of those children here also, and what has been found out that a significant proportion of young people wanting gender reassignment have autism, or they score very highly on the evaluation. So about 40 to 50% of young people asking for gender reassignment or suffering from gender dysphoria have autism, so which is a significant number. And it again makes the entire management incredibly complex. Sequelae of abuse I will come to, I think we need to. So let's go on to the mood disorder. As you know, mood disorders can be of two types, two primary types, major depression and bipolar disorder. There's a guy called Ghaziuddin. He has been publishing prolifically on this subject from 1990s. The prevalence of mood disorder in persons with autism, in young people with autism, in children with autism. As you can understand, the figures, the prevalence figures are hugely variable, 4 to 57%. You know, in our clinical experience, this is again very common and we don't pick it up. Specifically for children or young people who have left school or adults with autism, what happens is that until they are 18, 19, 20, persons with autism, young people with autism, they would be in a schedule. You know, they would be going to school, they would be having intervention, and after they are 18, when they leave school, there's a complete vacuum. And gradually, nothing active, you know, seems to happen. And our own clinical experience, a lot of the data from USA shows that these children or young adults are subsequently lost to follow-up. And it is when we come across them, we realize that they are just languishing, doing nothing, and they have significant mood disorder which is not being addressed. So I think this is something which we need to be mindful of when we are working with adults with autism, that their depression is not being picked up. The complicating part being, you know, the ability to express emotion in words is a difficult task for all of us. People with autism find it even harder, so therefore detecting depression or mood disorder in this population requires special vigilance. Again, anxiety disorders, it's very common. It is actually one of the commonest clinical presentation, at least in our experience. When we are working with children with autism, and you know, all our work with young people with autism has got a longitudinal course. So while we are, you know, scaling one small mountain after other, another small mountain after another, invariably at some stage anxiety disorder pops up and we have to deal with it. And the reason for which anxiety disorders actually come into play while we are seeing people with autism are again very obvious. Lack of problem solving skills, peer victimization is a crucial factor, and because we work a lot with high functioning kids, high functioning adolescents, many of them realize that they are different. You know, people don't like them, they can't go out on dates, they can't have friends, and I don't know how many of you have watched this American Netflix series called Atypicals, but if you haven't, you must. You must watch Atypicals, which is actually a fantastic Netflix series on an adolescent trying to date, an adolescent with Asperger's. It is hilarious, it is funny, it is poignant, but I think again it gives a very clear picture of what many of these adolescents go through when they are trying to, you know, become independent. Right, eating disorders, again, yesterday Ms. Shireen Idikula actually made a fantastic presentation. I don't know how many of you were there. See, there's a very clear overrepresentation of autism spectrum disorders in eating disorder population. There is a fantastic review by Hugh and Jeremy Turk. Jeremy Turk is one of the experts in developmental disorders, and this is a journal called Eating Disorders Review, and they have very, very you know, easy to read but a fantastic review on eating disorders and autism. And basically it says that there is a clear overrepresentation of autism spectrum disorders in eating disorder population. And again, the range of eating disorder prevalence in people with autism is about 6 to 17%. But eating problems are a lot commoner. Now, the current DSM-5 has, in a way, is proving to be difficult for researching this further, because it says that if there are eating problems in a person or a child with autism, you have to explain it through autism rather than eating disorder. But we know from clinical experience and with some empirical research that eating disorder and autism, they can coexist as a comorbidity, but the new DSM-5 criteria doesn't allow for that kind of comorbidity. So in a way it is going to be detrimental for research. What are the reasons why eating disorder and autism spectrum disorder coexist? Again, it's very easy to decipher. There's behavioral and cognitive rigidity, there's sensory abnormality, there's behavior with significant health risk, and also rumination. Rumination occurs in about 6% of children with autism. I have seen, to be honest, I have seen few, not many, but I think we are missing it. Because the literature says it exists, but possibly we are not sensitive, so therefore we do not pick it up. Now, this is a terrain really which is one of my favorite areas, but again I must say that this is an incredibly complex area. So I'm not sure how much sense I'm going to make. See, this whole relationship with autism and psychosis and schizophrenia is a vexed one. Autism at one point of time was called childhood schizophrenia. So there was a lot of diagnostic confusion. Over the years, there is a greater clarity in research, and now we know that we know certain facts. We don't know in the entire picture, but there are certain facts which we know. Fact number one is that individuals with autism spectrum disorder are at a greater risk of developing psychotic illness. That is, we know. One study indicates that the rate of psychosis in autism spectrum disorder could be as high as 28%. And remember, this is an astoundingly high figure. Even if we half this figure, 15%, so to have psychosis, which is a major mental illness, in 15% of the population in autism is a fantastically high number. For typically developing population, the figure ranges from between 2 to 4% if you take into account severe mood disorders, schizophrenia. So for a typically developing or for a normal population, the figure is around 2 to 4%. For in the autism spectrum condition, the figure, conservative figure, even if you think that 28% is too high, even if we half it, that is also astoundingly high number. And therefore, I think we need to be very, very mindful. And clinically, our experience, because I work in a team which is, has got very competent psychologists, special educators, and we do see young people and adolescents over a longitudinal period of prolonged period of time. There are certainly, they are far more prone to develop what we know as micropsychotic episode, very, very abnormal behavior. And what is, again, research has shown that the presentation of psychosis in persons with autism is very different to the presentation of psychosis in a normally developing population. So therefore, if you have autism and psychosis, and if you just have psychosis, the pictures are very different. The psychotic picture is very different. So it's not the same kind of psychosis which presents in autism compared to how it is presenting in a normally developing or in a normal population. The episodes are briefer. That is one of the main findings. As I said, the relationship is very complex. There are three probabilities. I'm actually not going to, because I'm running out of time. So there is a fabulous review article by someone called Larson and Simon Baron Cohen in 2017 British Journal of Psychiatry, which delves into this. I'm skipping the next 3 slides because for those who are interested, please do read this article, which is published by Larson and others in 2017 British Journal of Psychiatry, and it is absolutely a state-of-the-art article on psychosis and autism spectrum disorder. So let me skip the next 3 slides. I would actually just like to mention this part, that in people with softer versions of autism, we do get a huge number of people who actually have autism but have been misdiagnosed as schizophrenia. So I think the wrong diagnosis of psychosis when it does not exist in autism is also quite common, and as mental health professionals, we need to be mindful of that. Right, so I'm actually just showing my first slide again, and why is it more common? Obviously the seat of all problems in mental illness lies in the brain. And again, the hardwiring of the brain is different in autism. So therefore, it makes common sense that these two disorders will coexist. So mental illness arises in the brain, autism, the problem is rooted in the brain, so therefore these two things coexist. How much we know about it? We actually know very little for reasons which I have explained earlier. Somehow we haven't really looked into the real details of the nature of mental illness in autism spectrum population. And the question is, how is it important? You have to acknowledge that detection of mental illness in autism spectrum disorders is a lot more than an academic exercise. It is a lot more, because what you are doing is not going to work. Suicide is one of the worst possible outcome, and we have had young people who have just jumped and killed themselves, and then we have realized that we have missed diagnosis of mental illness. So it is not enough to just be working on the deficits which we can explain through autism spectrum disorder. All of us have to be mindful whether we are missing mental illness in this person. Why we cannot, diagnose or do a good risk assessment for suicide in persons with autism? Obviously, the language is a problem. We do not suspect it. The behavioral indicators might be too subtle, and therefore we miss it. I think how you would identify it, keeping it in your mind is the only thing. When you are working longitudinally, when you are suspecting or working for the first time, do keep in mind that this population is extremely vulnerable to develop mental illnesses. So keep that in mind, and I think once we are aware then we can ask for multiple sources of information. And trust me, most of the time, parents, mothers have said that yes, my child has been like this, but this is something different. And I think you have to go with that, because there are no validated tools, there are very few instruments which look into it. So keeping in mind the possibility of mental illness in this population is the key. Right, I have already spoken about the gender identity issues. The last point I would like to mention is that all of you know that in autism spectrum population, abuse is frighteningly common, you know, because of their vulnerability, because they may not be able to express, because of their high dependency need. So therefore, the sequelae of abuse, so you see a child, or you see a young person, or you see an adult with autism, and you suddenly realize that the picture, the clinical picture, the manner of engagement has changed. And that could be because the child or the young person or the adult has suffered abuse which we haven't picked up. So I think keeping in mind the sequelae of abuse is also very, very important. So this is my final slide. I have got 18 seconds. I have done fantastically well. So, you know, research suggests that prevalence is high. The prevalence of mental illness is high in this population. The risk of developing mental illness is also high. So therefore, in our intervention programs, what can we do which will prevent mental illnesses from happening in this population? What do we do? In absence of reliable diagnostic tools, I think clinical evaluation and keeping it in your mind is the only safety net. And, you know, I wanted to kind of term this presentation as widening the lens. So therefore, for all of you who are working in your own specialty, my request is to widen the lens so that you can include the picture of mental illness in this population. Thank you.